Yes, thank you, Dr. Pradhiva. Good evening, good afternoon, and good morning. This is the 1931st day of continuous webinar conducted by International Forum for Promoting Homeopathy. Today, our guest is Professor Dr. RINKU BISHWAS. Let us begin the session with 1 minute silent prayer. Thank you all. The International Forum for Promoting Homeopathy comprises of homeopathy lovers, students, and doctors. We have 3 sessions every day. The first session of the day is already over in Hindi from 7:30 to 9:30. From 9:30 to 10:30, from 8:30 to 9:30, we have the international session in English, and from 9:30 to 10:30, we have a local language session in Malayalam. We are uploading the videos of the same on the very next day itself, so that those who miss the session can watch it again, and you can subscribe the same without paying any money. And let me come to today's guest. And as you all know, today our guest is Professor Dr. RINKU BISHWAS, and he is working as the Professor, Department of Pathology, State Lal Bahadur Shastri Homeopathic Medical College, Prayarag, and has more than 21 years of clinical experiences and 17 years of teaching experience. And it's a very, very important subject to be discussed here in this evening, cardiovascular diseases and its homeopathic management. As you all know that homeopathy is a system where we treat all the persons with our individualization study. And let us see what Dr. Professor RINKU BISHWAS has to say about these cardiovascular diseases and its homeopathic management. We proudly welcome you, sir.
Thank you, sir. Sir, I am audible?
Yes, you're audible.
The screen sharing, you can see the screen, sir?
Yes, screen sharing and everything is fine. You can go ahead.
Good evening to all of you, my respected guide and mentor, Dr. Sahani sir, Dr. Danesh sir, Dr. Pratibha. My warm wishes to you and thanks to giving me chance on this platform to sharing my knowledge, sharing my topics regarding homeopathic and the disease. I am professor of pathology department and working in State Lal Bahadur Shastri Homeopathic Medical College as a HOD and professor. So I'm glad to share my topic with all of you. My topic is cardiovascular diseases and homeopathic management. Actually, there is a lot of diseases in cardiovascular system. So it is not possible to share about the all topics in one lecture. So we can cover the main topics of cardiovascular disease. Cardiovascular diseases are a group of disorders of the heart and blood vessels that impair normal circulation and cardiac functions. They are among the leading causes of morbidity and mortality of the worldwide. There are some diseases, common diseases of cardiovascular system: hypertension, high blood pressure, coronary artery disease, CAD, ischemic heart disease, also called myocardial ischemia, angina pectoris, initial stage of the MI or ischemic heart disease, myocardial infarction, may called acute myocardial infarction or heart attack, cardiac failure, congestive cardiac failure, arrhythmias, RHD, rheumatic heart disease and rheumatic fever, cardiomyopathies, peripheral vascular disease, and stroke also comes under the cover of cardiovascular system. If there is imbalance between the demand and supply of the heart to the blood to the heart may cause these type of situations. The etiology and risk factors are sedentary lifestyle. The person spend a sedentary lifestyle with unhealthy diet like drinking salt, sugar, high fat, smoking and tobacco use, the habits, alcohol consumption, living in the state of stress and anxiety, obesity, the weight gain or constantly gain the weight, one of the factor to development of heart disease or contributing to develop the heart disease, diabetes mellitus, hyperlipidemia, genetic predisposition of heart disease sometimes seen in genetical condition also, and advancement of the age, advancing the age in the old age. Common signs and symptoms in heart disease. Sometimes these symptoms may be similar that of gastric complaints, but we can identify and individualize the symptoms according to experience and clinically. Chest pain and discomfort. Chest pain generally in the precordial region or sometimes apex of the heart, and this type of pain may be radiated to the shoulder, right side or left side of arm, and maybe to the shoulder joint also. Chest pain and discomfort. This type of pain sometimes sudden or shooting type, or sometimes it is referring type. Shortness of the breathing, dyspnea, breathlessness or shortness of the breath. Palpitations. Sometimes palpitation is high, heart rate increases, tachycardia is there. Fatigue. Some patient feels fatigue and perspiring, sweating. Dizziness or syncope. Functions of the heart become diminished, circulatory time become sluggish, or patient feeling faint and dizziness. Edema of the feet and ankle. This type of seen due to the complications of heart disease, edema in the feet and ankles. Sometimes cyanosis, symptom of the cyanosis, or the condition of cyanosis, bluishness or lack of oxygen in this condition. This is the normal structure of the heart. All of you know, right atrium, left atrium, right ventricle and left ventricle. This is the normal structure of the heart. This is the major three vessels which supply the heart: right coronary artery, left coronary artery, and anterior descending branch of the left coronary artery. Generally, the major symptoms of the blockage in AMI or ischemic heart disease, there is involvement of anterior descending branch of the left coronary artery. 50% of the cases of AMI involve in blockage of this anterior descending branch of coronary artery. And then 30 to 35% left circumflex branch of the coronary artery and right coronary artery. So in the majority of the cases, sometimes in single vessel disorder, involvement of descending branch of the anterior descending branch of the left coronary artery, or sometimes 2 or 3 branch disorders may be. So we are discussing about some diseases of important disease of cardiovascular system. Pain disease, ischemic heart disease, also called CAD, coronary artery disease, or it is also called myocardial ischemia. ISD or CHD, chronic heart disease, congestive heart disease, defined as acute and chronic cardiac disability arising from the imbalance between the myocardial supply and demand of the oxygenated blood. The demand of the heart or ventricles are increased, but the less amount of the blood supplied to the heart. That's why heart not functioning properly, and myocardial ischemia or etiopathy result when there is an imbalance between the myocardial oxygen supply and demand. Most occurs because of the atherosclerotic plaque, which is one of the important cause. Within one or more coronary arteries, one artery involved or sometimes 2 or 3 arteries involved in the atherosclerotic disease. Limits normal rise to the coronary blood flow in response to the increased myocardial oxygenation or oxygen demand. The oxygen carrying capacity relates to the contents of the hemoglobin and systemic oxygenation. If oxygenation is not proper, there is hemoglobin percentage is low, or patient is anemic, and sometimes oxyhemoglobin not forms properly. That condition may causes decreased supply of the oxygenation. When atherosclerotic disease is present, the arterial lumen is narrowed and vasoconstriction is impaired, and then coronary blood flow cannot increase to the face to increase the demand, and ischemia may be result. So that it cannot fulfill the demand of the heart, and decreased amount of the blood causes myocardial ischemia and less supply of the oxygen. Causes of the IHD, coronary atherosclerosis, majority of the cases, 80-90% of the cases, there is coronary atherosclerosis or atheroma is the main cause of IHD. Other than atherosclerosis, superadded changes in coronary atherosclerosis, the changes or superadded changes in atherosclerotic branch, or non-atherosclerotic causes in which arthritis, vasospasm, other causes are involved. Coronary atherosclerosis, it is a separate topic, but it is major cause of the atherosclerosis is of ischemic heart disease. So that's why I'm discussing about the atherosclerosis distribution. Atherosclerotic lesions in coronary arteries are distributed one or more of the three major coronary arterial trunks. The highest incidence being in the anterior descending branch of the left coronary, followed in frequency by the right coronary artery, and less in circumflex branch of the left coronary artery. It means the chances of the blockage is highest in the anterior descending branch, then in right coronary artery, and then left circumflex branch of the coronary artery. About one third of the cases, the single vessel disease, the main branch which is involved is anterior descending branch of the coronary artery. Most often left anterior descending arterial wall involved, other than third two vessel disorder or three vessel disorder in which all three branches may be involved. Location. Almost all adults shows atherosclerotic plaques scattered throughout the coronary arterial system. However, significant stenotic lesions that may produce chronic myocardial ischemia show more than 75%, approximate 3/4 percentage reduction in the cross section area of the coronary artery or its branches. The area of the severest involvement is about 3 to 4 centimeter from the coronary ostia, more often at the near the bifurcation of the arteries where the artery is dividing or branches ramifying, suggesting the role of the hemodynamic forces in the atherogenesis. Sometimes this type of blockage form near the bifurcation or where the arteries ramifying or bifurcation is there, because of at that point the for hemodynamic forces may be altered in some extent, and chances of the formation of clot or blockage may be formed. Fixed atherosclerotic plaque. Fixed type of plaque is formed in fixed area of the arteries. The atherosclerotic plaque in the coronaries most often eccentrically located, bulging into the lumen from one side. First side of the artery may be involved, and it gradually increases in the size and blocks the lumen completely. Occasionally, there may be concentric thickening of the wall of the artery. Atherosclerosis produces gradual luminal narrowing that may eventually lead to the fixed coronary obstruction. Continuous growing in the size may causes 70, 80 or 90% blockage of the lumen. The general features of the adenoma of coronary arteries are similar to that effect elsewhere in the body. This type of adenoma produce similar effect. It may produce in brain, spleen, other vessels. Same effect produced in the heart. It is ischemic effect, and may develop similar complications like calcification, coronary thrombosis, ulceration, hemorrhage, sometimes rupture or aneurysm formation. These are the complications of atherosclerosis or some superadded changes in the coronary atherosclerosis. Acute changes in the chronic atherosclerotic plaque, coronary artery thrombosis, local platelet aggregation, and coronary artery spasm. In such cases, acute changes in the chronic atherosclerotic plaque is sometimes there is due to the hemodynamic force or high blood pressure, there is dissecting of the blood vessel. Sometimes there is aneurysm formation, or blood may enter into the between the layers of the arteries and causing bulging or aneurysm formation, and sometimes platelet aggregate at the site and may produce thrombosis. Coronary artery thrombosis at the site where the coronary artery or endothelium become injured, where thickening or sometimes aggregation of platelets causes obstruction and thrombosis formation, and at the area is sensitive for the local platelet aggregation, and coronary artery may be produce spasm at that area. Effect of the ISD. The ischemic heart disease may produce this effect sometimes initial stage. If ischemia is an incomplete type or partial type and complete artery is not blocked and there is some way to pass the blood, the symptom may be asymptomatic, person may be asymptomatic, or sometimes produce phasic symptoms initially. The symptoms may be not recognized by the patient. Afterward, condition comes that is angina pectoris. That is initial condition of the AMI, and you may say that it is a warning condition or warning sign of development of the ischemic heart disease. Then acute myocardial infarction. If we ignore the angina effects and we can't change our lifestyle, don't take the medication, then the warning sign may turn into the acute myocardial infarction or heart attack. And then sometimes if patient survive, then he suffer from the severe cardiac disorders and change the chronic ischemic heart disease. And sometimes if survival is not possible and there is complete blockage of the artery due to the complication of the heart attack, patient may die or sudden death may be produced. Angina pectoris. It is the warning sign or initial condition which gives of warning that we take precautions and change the lifestyle and take the medications. Angina pectoris is a clinical syndrome of ischemic heart disease resulting from the transient myocardial ischemia. This it may last for the few seconds to the few minutes. It gives a warning sign. Sometimes it is very minor and pass within the few seconds, and sometimes it may be last for few minutes also. It is characterized by proximal pain in substernal or precordial region near the heart or near the apex of the heart or in the region of the chest, and which is aggravated by an increase in the demand of the heart and relieved by the decrease in the work of the heart. If you cause any physical exertion, if you rising on stairs or puts on some weight, or you are walking or running, then demand of the heart increase. That time the symptoms get aggravated. And if you lie down or produce less demand of the heart or relax the heart or decrease the work on the load on the heart, then you can feel relaxed. Often the pain radiate to the left arm. The pain may be shifting type, and sometimes there is some symptoms of the gastralgia or some nausea and vomiting type. Patient seems that this pain may be gastric type, but along with the pain radiate with the left arm, neck, left side of jaw, or sometimes it radiate to the right arm of the jaw. That is the warning signs, and we can see these are symptoms of angina pectoris. It is more common in the men after the 50 years of the age. There is three type of angina pectoris. Number first, stable angina. Stable angina is chronic pattern of the transient angina pectoris precipitated by physical activity and emotional upset, relieved by the rest within the few minutes. This type of angina may aggravated by any exertion, rising the stairs, by any walk, cycling, walking, running, any physical activity, or sometimes due to hearing any bad news or emotional upset, you crying at the time of lacrimal disposition. This attack may be precipitated angina, and sometimes it is spontaneously relieved or relieved by the rest or lying down or normal within the few minutes. In this condition, there is temporary depression of the ST segment and no permanent myocardial damage. At the condition of myocardial infarction, there is some changes in the myofibrils, ventricles, and we can see in the muscles also. But these changes may be not permanent type, and ECG shows slight depression of the ST segment in initial condition. Second type, premental variant angina. Premental variant angina, typical angina type, discomfort usually at the time of rest. This type of angina, patient can feel the attack of the angina at the time of rest also. No relationship between the physical activity, like unstable angina that comes at the time of physical activity. This type of angina may come at the time of rest also. Develops due to the coronary artery spasm rather than increased myocardial oxygenation demand. Transient shift of the ST segment. In ECG wave, it shows ST segment elevation. ST segment elevated temporarily at the time of premental variant angina attack. Silent ischemia. Sometimes we can see at the time of night when patient lying. Sometimes asymptomatic episodes of the myocardial ischemia detecting by the electrocardiogram and laboratory studies. There is patient is normal, no sign and warning sign seen, but patient if done ECG, then this type of changes detected by the electrocardiogram or laboratory studies. Otherwise, patient spending a normal life, but there is obstruction 80 to 90% in the coronary arteries may be observed. So, stable angina, premental variant, unstable angina. That is increased frequency and duration of the angina. Repeated attack of the angina pectoris and repeated episodes of the angina pectoris felt by the patients produced by the less aggression. There is slight emotional upset or slight exertion may cause precipitate of the attack. High frequency of the myocardial infarction is not treated, and pre-infarction angina most serious pattern of the angina. It is a condition which is prior condition of the myocardial infarction. It is a serious pattern. If there is a repeated attack of the unstable angina, it causes severe cardiac derangement of disabilities. So it's about myocardial ischemia or coronary artery disease. If this condition constant for a long period or repeated attack of the angina may causes acute myocardial infarction. It is called acute condition because patient may die, or if patient survive, he lives with cardiac disabilities, and the area of the myocardial infarction we can see histologically or histological section. Other name is cardiocoronary occlusion or heart attack. Myocardial infarction refers to the process by which the myocardial tissue is destroyed in region of the heart because of the reduced coronary blood flow, a prolonged lack of the myocardial oxygenation leading to the necrosis of the portion of the heart muscles. If patients survive, we can see the area of the necrosis in ventricles. Sometimes it is maybe pancarditic. All three layers of the heart may be involved, but major portion of the necrosis we can see in the ventricles or heart muscles. That area, because if 4 to 5 minutes if doesn't heart doesn't receive the blood supply, the area of the heart muscle may be died or necrosed. So myocardial area in which the area of the muscles of the heart may destroyed or necrosed due to the severe and constant ischemia. Myocardial infarction, etiopathogenesis, causes of the reduced blood flow, narrowing of the coronary artery owing to the atherosclerosis. Atherosclerosis is also a cause of myocardial ischemia and acute myocardial infarction also. A complete occlusion of an artery owing to the embolus or thrombosis. The obstruction may be due to sometimes previously patient suffering from the atherosclerotic condition, and 80 to 90% vessels blocked with this atherosclerotic plaque, and remaining 10 to 20% artery blocked due to the embolus and thrombus, and sometimes sudden vasospasm may causes complete blockage of the artery, leads to the cardiac arrest or heart attack. Myocardial necrosis caused by the acute occlusion of the coronary artery due to the plaque rupture or erosion with the imposed thrombosis. The thrombosis may circulate as a thromboembolism from the other side of the body, from the lower extremities, from the lungs may come, and due to the traveling, it lodges at the area of the narrowing or area of the atherosclerotics and causes temporary blockage of that area. It stuck at the area of the narrow atherosclerosis, and cessation of the blood or severe ischemia lead to the stop cessation of the blood and cardiac arrest or heart attack may be supervenes. Acute myocardial infarction is the most important and feared consequences of the coronary artery disease. Many patients may die within the few hours of the onset of the myocardial infarction because in initial condition, if cardiac attack precipitated, then patient doesn't having much time, or the relatives or the family members doesn't have much time to take the patient to the hospital, and if it is mistaken, misdiagnosed, or sometimes may patient misleads with the gastric complaints, so proper treatment not given at the time and the window period is over, and within the few 30 to 40 minutes to 1 hour, that is the golden period or window period in which we have to take the patient to the hospitals. So many patients may die within the few hours to the lack of the emergency treatment or misdiagnosed, while the remainder which suffers from the impaired cardiac functions for a long period. If patients survive from the cardiac attack and blockage may be 90% or maybe chronic cardiac patients, and after the subside of attack patient survive, he remain his life with the severe impaired cardiac function dysfunctions. A significant factor that may prevent or diminish the myocardial damage is the development of collateral circulation through the anastomotic channels over a period of the times. If sometimes we see in the chronic cardiac patients, all three major vessels are blocked, but patients survive and living remaining life for 5 to 10 years. So, due to the some collateral channels may be developed over a period of the time, and which gives a bypass road for the circulation of the blood. So patient survive and lives for few years also. A regular and well planned exercise program encourages good collateral circulation and improve cardiac performances. If patient survive with chronic cardiac disability, so and patient is very aged, so it is not possible for patient, and patient is sometimes maybe diabetic, it is not possible to do any surgical work, angioplasty or bypass surgery. So a well planned programmed exercise with medication, with homeopathic medicine, encourage the good development of good collateral channels. If we successful into development any collateral channels into proper blood supply, it improve the cardiac functions and cardiac performance, and patient may survive for 5 to 10 years extra life. So, medicine can help in the severe cardiac disability to develop collateral channels also. The age acute MI may virtually occur at all ages, through the incidence is high in elderly persons. About 5% of the heart attack occurs in the young persons under the age of 40 years. We see many of the persons died at the age of 40 or below the 40 years age due to the sudden cardiac arrest or sudden heart attack. They are while they are working in gym, exercising in the gym, or doing any job at the time of sleep also. So it all depends upon the patient's physical condition, previously lying any major diseases, diabetic factors, hypertension, cigarette smoking, chronic history of dyslipidemia. We can see all these stages may major contributing factors in development of the chronic cardiac disease, and sometimes sudden vasospasm or sudden patient artery may be blocked 70 to 80%, 90% previously, but patient living a normal life. But a stage comes when there is sudden vasospasm or vasospasmic attack due to the any sudden adrenalic discharge or due to any neuroadrenal discharge, some sympathetic outflow may cause sudden vasospasm. That condition may lead to the sudden cardiac arrest, and patient may die at the time of working or doing exercise in the gym also. So age is a factor. Generally, the myocardial infarction or heart attack may seen after the age of 50 or fifth decade. But recently, or we can see at the present scenario, many of the cases starts in early 30s and at before the 40 years of the age also. Sex males throughout their life are at a significantly higher risk of developing acute MI as compared to the females. We shown and seen the less cases of the female myocardial infarction or attack, but majority of the cases males are the more sufferer of the heart attack. Women's during the reproductive period has remarkably low incidence of the acute myocardial infarction. That suggests the estrogen hormone may be as a work as a protective hormone, and influence of the estrogen also helps in maintaining the normal function of the heart, normal muscle tonicity of the heart, and ventricular contraction and functions. It's used to the use of the oral contraceptive is associated with the high risk of developing AMI. The ladies who taking frequently oral contraceptive pills or estrogen pills and other contraceptive pills, the incidence or tendency of development of the acute myocardial infarction increasing than in that ladies than other females. Causes: myocardial ischemia, role of platelets, complicated plaques, non-atherosclerotic causes, transmural versus subendocardial infarct. Actually, causes are similar that of congestive cardiac failure, acute myocardial infarction, coronary artery disease, myocardial ischemia. But severity or duration and involvement of the which vessels, it is very important in the case of previous history of the patient suffering from any other chronic disorder, diabetic, hypertension, taking any medicines or pills. They are the contributing factors. So complete case taking of the patient is essential in such cases. Myocardial ischemia, if patient suffering from a many years from the myocardial ischemia or coronary artery disease and doesn't taking proper medications or any suggestions of the cardiologist, and sometimes the sudden attack may be precipitated due to the sudden blockage of the vessel or due to a sudden thromboembolism or sudden vasospasm. Role of the platelets: sometimes viscosity of the blood become high, patient may be anemic, hemoglobin content may be low, sometimes patient's ESR become high, patient is allergic and thrombotic. If patient is chronic smoker, then viscosity of the blood become high blood vitamin K level, and thickness of the blood. Sometimes blood vessels disorder, or sometimes the blood cells disorder may lead to the platelet aggregation and thickening platelets at the site of thrombotic plaques. So platelet aggregation may lead to the thrombosis formation and myocardial ischemia. Sometimes plaques, atherosclerotic plaques, gets complicated with increased flow of the force of the blood due to atherosclerosis, due to the high blood pressure, due to the high hemodynamic forces, and sometimes plaques may be ruptured, sometimes plaques may be dissected, blood may be entered inside the endothelium, or sometimes aneurysm may be formed. The complicated plaques at the site of ulceration and their aggregation of the platelets and causes of the obstruction may be seen in such places. Non-atherosclerotic causes. Non-atherosclerotic causes including vasospasm, arthritis, small artery disorders, any ergot poisoning, the case of Burgers disease, or sometimes we can see sudden vasospasm in low temperature area or in minus temperature, or other than many disease which is non-atherosclerotic may causes sudden vasospasm or narrowing of the vessel. So arteries, small vessel disorder, or sometimes in congenital disorder, maldevelopment of the vessels may be caused. Transmural versus subendocardial infarct. Transmural, which is involvement of the all three layers of the heart, or endocardium, pericardium, and myocardium, all three parts of the involved, and entire thickness may show infarction, and sometimes subendocardial infarct. The subendocardial region may involve in the infarction, as we seen in the RHD or myocardial infarction also. Myocardial infarction is the depth of the myocardium, the which area and thickness of the myocardium involved in this infarction. That is, transmural involved the all thickness of the heart. Subendocardial may be laminar, or crescentic area of the infarction may be seen, and that condition is may better than transmural condition. So involvement of the part, involvement of the thickness of the heart, which arteries involved, previous condition of the patient, last and duration of the ischemia, that is important factor in the case of AMI. Type of the infarct. According to the anatomical region of the heart ventricle, in which artery involved, which anatomically which area of the ventricle involved, according to the degree of the thickness. It means one third area, two third area, or entire thickness, that is transmural thickness, may be involved. That condition is more worse than the crescentic form, or sometimes semilunar type form जो है. According to the age of the infarct, recent infarction and involved of the large area may be fatal. Sometimes old infarct, which is seems pale, or some shrunken area or dry, which is less dangerous or less fatal than fresh and recent infarct. Location. Which area is involved? Stenosis of the left anterior descending branches. As I already told you, the 50% of the cases of the AMI generally seen in anterior descending branch of the coronary artery, because it is a branch which is longitudinally stands, and the effect of the hemodynamic changes and bifurcation of vessels or blockage of the arteries, thrombosis formation seen in this area or this artery also, and stenosis of the right coronary artery, and stenosis of the left circumflex, which is least important and sometimes seen in the less cases. Highest incidence seen in the anterior descending branch of the coronary artery. This is diagrammatically show 50 to 40%, 40 to 50% anterior descending branch of the coronary artery, 30 to 40% right coronary artery, and 15 to 20% which is in the left circumflex coronary artery. Less common. Sometimes two or three major vessel disorder may involve the all two or all three vessels, major vessels. In such cases, we have to go for angioplasty or some other bypass treatment. Myocardial infarction, clinically, the symptoms are pain in the cardinal symptoms of MI, anxiety, fear of impending death, nausea, vomiting, breathlessness, collapse, and syncope. Sometimes, if cardiac arrest or sometimes myocardial infarction or heart attack supervenes, then symptoms The pain and great apprehension. Patient afraid for the death and fear of the death may be seen on his face. There is restlessness and anxiety. Patient sweats profusely. The face or body become wet due to the sweat. Pain in the precordial region may be radiate to chest, left side in left shoulder, or sometimes in neck and jaw. And patient uh, put your hand on the substernal or precordial region. Sometimes symptoms of the nausea and vomiting may be predominant. It seems like these gastric complaints, but along with there is if increase or profuse sweating on the face, patient's body wet due to the sweat, get apprehension scene and the chest pain. Along with this scene, we can go for the emergency treatment and take the patient to the hospital. And breathlessness, sometimes patient dyspnea or breathlessness due to the syncope, and sometimes symptoms of the cardiac collapse may be seen. Patient may be faint due to the worsening the function of the heart. Clinically, how we detect or diagnose the myocardial infarction? Initially, the 24 hours are very crucial. Initial 40 minutes or 30 to 40 minutes are window period and golden period. If the that period, if we give the patient to emergency treatment or take the patient to the hospital, and we can successful to survive the patient. But initially, the first investigation, if when to take the patient to the hospital, that is ECG. Continues, we can see the physical signs of the patient and observe them. There is signs of the sympathetic activation, sympathetic stimulation, that is pallor, sweating, tachycardia, fear and great apprehension seen on the face of the patient. Otherwise, signs of the vagal activation like nausea activation. If vagal stimulation is high, or sympathetic outflow high, it activates and stimulates the heart as well as stomach also, GIT also. So there is increased stimulation of the nervous center, nausea center, vomiting center, and nausea and vomiting and salivation in the mouth. Symptoms are also associated with the tachycardia, bradycardia, sometimes may be seen in the indigestion symptoms also, acidity, and sometimes this vomiting also. Sign of the impaired myocardial functions like hypotension, the body become wet, pulse is sluggish, and oliguria, patient fatigue and faint, BP become low, and extremities and peripheral part of the body are become cold to touch and wet with the sweat. Signs of the complication, the symptoms of the metal regurgitation and pericarditis may be seen. Some diagnoses are important because sometimes this symptom may be related with the other cardiac disorders. Sometimes it is GIT complaints. So how we can diagnose the cases? Initially, at first we take to the patient ECG done, and some ECG findings are very important to detect the patient, whether patient suffering from cardiac disability or myocardial attacks supervise or not. ECG, one by one we discuss all these tests. Some blood test which is also important, initially 24 to 48 hours, that is myocardial enzymes, cardiac enzymes, which is elevated at the time of cardiac arrest or heart attack, and after the but 72 hours this cardiac enzyme may be disappear from the blood. Then if we done this enzymatic study after the 2 or 3 days, we can't detect the level of these enzymes in the blood because they disappear within the 48 to 72 hours. So cardiac enzymatic study should be done in the within the 24 hours to 48 hours. Creatine kinase, myoglobin, creatine kinase, MMBB and MB11. Lactic dehydrogenase, cardiac troponin, and myoglobin level. These all are elevated at the time of cardiac arrest. The study of the enzymatic study is very important for the cardiac patients. Then echocardiogram, nuclear scan, chest radiograph, coronary angiography. If patient is stable, after the stable condition, we do coronary angiography, exercise and stress level test, cardiac computerized tomography, CT scan, and sometimes MRI done for the patient. Creatine phosphokinase. What is creatine phosphokinase? There is three type of creatine phosphokinase, that is creatine kinase MB, creatine kinase MM, which derived from the skeletal muscles, creatine kinase BB derived from the brain and lungs, and creatine kinase MB, which is derived from the myocardial cardial muscles, and that is significant for about the extracardiac tissue. So total CK estimated lack specifically, while the elevation of the CKMB, this isoenzyme is considerably specific for the myocardial damage. Its level of the CKMB is elevated, that is a sign of myocardial damage. So it is also CKMB is also two forms. CKMB2 is the myocardial form, which CKMB1 is extra myocardial form. So the form of CKMB2, which is cardiac form, that may be elevated, the CKMB2 or CKMB1 level above 1.5 is highly sensitive for the diagnosis of acute myocardial infarction after the 4 to 6 hours of the onset of the myocardial ischemia. If myocardial attack precipitates within the 4 to 6 hours, we should done this type of study. Myocardial MB level disappears from the blood after the 48 hours. So this study should be done in within the 24 hours of the attack. Next enzyme is lactic dehydrogenase, LDH. This level is also increased at the time of cardiac arrest. Total LDH estimation also lacks specificity since the enzyme is present in various tissues besides myocardium, such as skeletal muscles, kidney, liver, lungs, RBCs. However, like creatine kinase, LDH level also increases. Isoforms of the LDH are LDH1 or LDH2. LDH1 is myocardial specific type of enzymes. The ratio of the LDH1 or LDH2 above 1 is reasonably helpful in making a diagnosis. LDH, lactic dehydrogenase level, begin to rise within the 24 hours, peak at the days 3 to 4, 6 days, and return again normal after the 14th day. Cardiac troponin. Immunoassay of the cardiac troponin as a serum cardiac marker has rendered LDH estimation obsolete. Troponins are contractile muscle protein present in the human cardiac and skeletal muscles, but cardiac troponin are specific for the myocardium. There are two types of the cardiac troponin T and cardiac troponin I. Both cardiac troponin T and cardiac troponin I is not found in the blood normally, but at the time of cardiac arrest or myocardial injury, the level of same times creatine phosphokinase elevated and cardiac troponin level also elevated. Both troponin levels remain high for much longer duration. Creatine kinase or cardiac specific troponin for 7 to 10 days, and creatine cardiac specific troponin T level approximate 10 to 14 days, and again it came normal after the 2 weeks of the cardiac arrest. Myoglobin is the first cardiac marker to become elevated after the myocardial infarction. It lacks cardiac specificity and is exerted in the urine rapidly. Its level turns normal within the 24 hours of the AMI. It means it is increased in the 24 hours, and after 6 to 7 hours it can detect in the blood, and it also excreted through the urine also, and again normal after the 24 hours. There is some ECG studies that is important for the myocardial infarction. If patient feels such type of symptoms, we can do the ECG. Some important findings we can see: this is normal ECG, PQRST wave. ST elevation, very important. If we seen ST elevation, this is sign of myocardial damage and myofibrils damage. T wave inversion. T wave inversion also shown the myocardial damage and ischemic attack. And Q wave deepening, that's very important. Q wave deepening sometimes seen in the case initial phase of the heart attack or myocardial ischemia, and or where heart attack may be precipitated. Or sometimes we can see elongated R wave, and sometimes PQ wave inversion, that also shows the myocardial derangement or damage of the, or sometimes ventricular hypertrophy. If R wave elongated, we can suggest that ventricular hypertrophy is there. So these are the some important ECG markers. If this type of ECG findings shown in the ECG report, then seriously taken, and that the treatment guideline for the cardiac disease properly followed. Diet chart, medications, all things seriously followed if patient wants a normal life. Myocardial infarction, other medical management, immediately take to the patient to the hospital, immediate management within the 12 hours. Sometimes analgesic antiemetic treatment may be done, antiplatelet therapy or anticoagulant therapy, antithrombal therapy like streptokinase or urokinase treatment immediately given to the patient, so that immediate dissolve the thrombus and clear the way for the circulation. Anti-anginal therapy and sometimes surgical or stent bypass therapy. If patient survive, then we can give the homeopathic medication, and the proper diet chart, proper lifestyle, and the medicine help to improve the other collateral channels for the survival of the patient. But if the patient condition is critical, we can give the stent therapy or sometimes bypass surgery. So stent therapy or angiography, if patient stable, then the cardiologist do the angiography and see the where is the blockage, it whether it is single branch disorder, two vessels disorder, or all three major vessels are involved. If all three vessels are involved or two or three vessels disorder is there, so there is stent implantation done by the physician or cardiologist. Stent is a small spring-like structure which is inserted in the vessels where the blockage is there. This is the process, stent and ballooning process. It is introduced by the brachial femoral artery and inserted at the site of blockage like this, and then it after entrance balloon catheter covered all the stent, and then balloon may be swollen and blown into the succusis atheroma to wide the artery. If blown, expand this spring and extension of the balloon along with the spring, then we let down the balloon and push it out, and stent remain placed at the time of, and it widened the artery also. This is the procedure of stent implant. Stent is a small spring like structure, and after the deballooning, stent remain inside the artery at the area of the blockage, and catheter and balloon is removed from the site. So this is the stent implantation. This small meshwork inserted in the blood vessel coronary artery at the area of the blockage. The life period of this stent may be 3 to 5 years depending on the quality and material of the stent. Normal expenditure for this stent implantation is 50,000 to 1 lakhs depending upon the material cost of this stent. But if there is major vessel disorder, two or three vessels are involved, one vessel is involved at the two or three site, or all three major vessels are involved, then stent implantation is not successful. Then the cardiologist or cardiac physician do the bypass surgery. In bypass surgery or bypass, yeah, open heart surgery, they take a piece of vein, generally saphenous vein or femoral vein, and graft it at above the area of obstruction, and another site is after the area of the below the area of obstruction, and make a bypass graft for the circulation of the blood. This is called open heart surgery. So the part of homeopathic remedies or homeopathic treatment, I already told you, if patients survive and initially the initial condition of the cardiac derangement or patient suffering from the cardiac complaints come to the homeopathic physician, we can help the patient to develop the collateral channels, maintain the cardiac tonicity, and with the diet regimen and patient's lifestyle change, we can patient can survive for a for 5 to 10 years extra with the cardiac derangements, cardiac problems. So important homeopathic medicines, which is helpful and sometimes did a miraculous result for the cardiac patients. Main medicine Crataegus oxygen था. It is also known as cardiac tonic or heart tonic. Very well known cardiac tonic, useful in the cardiac failure, angina pectoris, valvular heart disease. Sensation as if the heart would stop if the patient moves, improve cardiac muscles, tones and circulation. That is important feature of the Crataegus oxygen था. It used in the potency as well as mother tincture and very helpful medicine for the heart patients. Second medicine is Digitalis purpura. Very important medicine. It is very important for the cardiac patients. Slow, weak, irregular pulse. Patient is cyanotic, dyspnea, feeling as the heart will stop on the motion. If patient do least motion, the heart will stop. Seems the patient. That is very useful symptom and useful in the advanced heart failure in under strict supervision. Additional with the treatment of the cardiac physician, we can use the digitalis for improve the cardiac functions. Next one is also called cardiac tonic, Cactus grandiflorus. Very important medicine, very useful medicine, and globally a medicine used. Constrictive sensation around the heart, and patient feels the heart is cased with the iron bands and constriction feeling. Very important for the constrictive cardiac failure, congestive cardiac failure, and CCF. Angina pectoris, palpitation with the anxiety, and sometimes in angina, pain radiate to the arm. Very important symptoms of this cactus grandifolia. Patient feels that heart is cased and tied with the iron band. That is important symptom. Strophanthus hispidus, cardiac weakness with the edema, shortness of the breath, and exertion, useful in the valvular heart disease. It is patient medicine generally used in the RHD, rheumatic heart disease, valvular heart disease, mitral stenosis, and aortic stenosis. Rare medicine, but is very important. Adonis venalis, very important medicine. Weak heart with dystrophic changes, ventricular atrophy, sometimes irregular pulse, sometimes associated with the inflation of the lungs or emphysema, in which heart size become reduced, and rheumatic heart conditions with the constrictive pericarditis. This medicine is very useful. Oramet, hypertension with the depression. Patient having depressive insanity. Patient is morally very low with the cardiac complaints. Patient is very disappointed, having the suicidal tendencies and strong sense of the responsibilities, palpitation, anxiety, and suicidal thoughts. That is important for the Oramet patient. High grade of the suicidal insanity seen in the patients. Lachesis, very important. Left-sided heart complaints, palpitation, worse after the sleep, intolerance to the tight clothing. Patient can't wear the tight clothing, and contradiction. Menopausal cardiac complaints, cardiac symptoms. Patient is having great loquacity. The patient and night complaints, night aggravated, and sometimes silent attack. Lachesis is very important. Glonoin, acute condition, acute sudden congestion of the heart and heart throbbing pulse, hypertension, shooting of the blood, pressure with headache and worse from the sunset and temperature. NASA, very important, vascular heart disease, viscosity of the heart become bleeding tendencies, palpitation, anxiety, pain radiate from the left shoulder to the arm associated with the emotional disturbances. And this type of symptoms if appear, NASA, very useful medicines. Spigelia, left-sided complaint, neuralgic complaints, patient having pain in the heart area with the neuralgic pain in the heart, pain radiate to the left arm and neck, palpitation worse with the movement. Slight or least exertion may causes the disturbance and cardiac palpitation. And other than this, carcinic album, calcarears, many medicines are useful according to symptom similarity. And other this, along with the indicated medicine or remedy, changes of the lifestyle and preventive measure are very important to patient. The additional precautions should be taken by the patient and guided by the physician. That is balanced diet, low salt diet, low fat diet, regular physical activity, stress reduction techniques like yoga, meditations, walking, exercise, adequate, but don't ask the patient to take the violent and dynamic exercises. Small household exercises with less dynamic activity, that type of exercises should advise to the patients. Patient advised to take adequate sleep, avoid the tobacco, excess of the alcohol, and regular medical checkup and physician advice regularly taken by the patients, and regular visits of the patient to the physician should be advised to the cardiac patients. So this type of management along with the proper advice, management, yoga, exercise, lifestyle changes and suitable homeopathic medicine should be taken by the patient, so we can increase the patient's life 5 to 10 years with the chronic cardiac disability also. So, few cases of the heart like AMI, congestive cardiac failure, or ischemic myocardial ischemia discussed today. Homeopathic medicines are offer a holistic and individualized approach to the management of the cardiovascular disorder, focusing on the symptom similarity and constitutional treatment. It plays a very important supportive role in chronic cardiac condition, especially in development of collateral channels and preventive, while emergency and acute cases require the immediate conventional medical care. So we should understand the status and condition of the patient and give the adequate treatment and homeopathic management. So thank you, sir. That's it. Anybody want to ask any question or query? So
Thank
welcome.
you. Thank you, Dr. RINKU BISHWAS. It's really a very good session, and you really rock the floor with your knowledge in cardiology as well as your expertise in the field of cardiology. Hope that you can come up with some case presentation in the coming edition so that we can show the world that homeopathy can do such wonders in cardiology cases, in managing cardiology cases. But unfortunately, due to lack of time, we are unable to show the cases. And sir, what is your success rate in treating cardiological patients? And
Sir, actually, chronic cardiac patients, if patients survive from the heart attack or cardiac arrest, and it also depends upon the age of the patient also. A patient living in the in fifth to sixth decade, then precautionary manner, lifestyle changes, yoga, medications, other medicines should be advised to the patient. Actually, if patient become a cardiac patient or cardiac derangement, the remaining life patient should take care with the lifestyle changes, with the medications, with the diet, with the management, and he should take homeopathic medicine. So if he take homeopathic medicines along with the lifestyle changes, the patient lives his normal life. Life expectancy is not reduced with the heart patients. If patients lives and with the management and proper care of diet and take the homeopathic medicines. So,
oh,
uh, it advises the patient doesn't take any dynamic work, exercises, or some other type of activities which aggravate the symptoms. So, with the precautions, patients lives a normal life and life expectancy doesn't reduce. I see in many cases.
okay, sir. Okay, sir. Now I am inviting Dr. Sridhar Kurpsar to say vote of thanks to the session.
So, Dr. R.K. Vishwas, your class was excellent. I heard only very few minutes, more than half an hour it was over. Anyway, however, it was, what I heard was very excellent. Thank you very much. I thank all the participants and also especially Dr. R.K. Vishwas and all others who are regularly attending. I sincerely thank you all. Come again, and every day you come. Thank you very much in behalf of IFPH. Thank you very much.
Thank you, sir.
Thank
Thank you, Dr. Sridhar Kurpsar. Tomorrow we will have a session from Dr. Jessica Monterio, and Doctor will be talking about exploring the non-verbal symptoms of common homeopathic remedies. Please, those who missed the session can watch the videos of the session tomorrow evening. So that kindly visit IFBH Homeopathy at YouTube. With that, we come to the end of the day. Sir, do you want to speak and say anything? Dr. Vishwas, do you
No,
want to
sir.
speak?
No, sir. No, sir.
Okay. With that, we come to the end of the day, 1932. Thank you all. Good
Thank you,
night.
sir. Good night.
It's over to Dr. P. Shaila to moderate the Malayalam session.